Hello everyone, it's Dr. Locklear again, and we're continuing our focus on immunity, and we're going to be talking about Exemplar 8C, which is rheumatoid arthritis. And so you wonder, why is rheumatoid arthritis in immunity? Because this is considered an autoimmune disorder, and so it does fall under this category. And so what is the patho? How does osteoarthritis and rheumatoid arthritis work? And we're going to talk about how the body's immune system takes us to a place where it's kind of attacking itself, so to speak. What's the causes of rheumatoid arthritis? What are our risk factors? And what do we see? One of the things that we see, and if you'll look on page 528, you will see someone that has rheumatoid arthritis in their hands and how it disfigures their fingers and their joints and causes all kind of nodules and just a deformity of the different types of bones. What are the diagnostic tests that we look at? How is it diagnosed? And how do we differentiate the care of patients? We do see this in older adults mostly. And of course, how do we apply the nursing process? What is our assessment focused on in our nursing diagnoses? And then how do we treat someone with this disorder? So our overview, rheumatoid arthritis is a chronic systemic autoimmune disorder. So that means it's within yourself. Your body is attacking itself. A disease caused by abnormal overactive functioning of our immune system, and it produces a response against the body's own cells and our tissues, normally resulting in damage to the tissues. And so as our body it sees us as foreign, and so our immune system says, hey, I'm going to attack you, and that's what it does. RA causes inflammation of the connective tissue, primarily in the joints, so that's why you see disfigurement in the joints. Manifestations can be minimal. Sometimes it just occurs overnight. You can go to bed and wake up and have very stiff and achy joints with the swelling in the joints. You can have mild inflammation of only a few joints with a little structural damage, or it can be relentlessly, which is never stops, progressive, and you can have multiple inflamed joints and marked deformities. RA contributes to disability and tends to shorten life expectancy. It is very painful, and as you see on the slide here, it causes chronic pain. These people deal with a dull, achy pain all the time. It never really goes away. And some of the medicines that they take for inflammation are not very good for the kidneys, so you may not be able to take anything. A lot of these drugs also affect the GI tract as well. Most patients exhibit a pattern of symmetric involvement of multiple joints and periods of remissions. So there may be times in the milder cases that you do have moments where the pain is not as bad and the damage is not as rapid and progressive, but then you can have periods of exacerbation that feel like they never end. Patients who are diagnosed with RA must cope with chronic pain, as I said. They experience alterations in their body image. A lot of them have what we call double knee or knot knee. The bone tissue just grows in an abnormal direction. Many deformities in the hands and the joints and the fingers of the hands, and you see those pictures in your chapter here. They often require specifically modified tools to allow them to perform activities of daily living. So they may have to use things like hand tools to feed themselves, or walk-ins or canes and things like that to be able to function. Our patho is long-term exposure to an unidentified antigen is believed to cause an aberrant immune response in a patient who is genetically susceptible. So there may be a genetic link here. As a result, normal antibodies, your immunoglobulins, as we talked about in hypersensitivity, become auto-antibodies and attack the host tissue. And so they see your body as something foreign, and they don't know what triggers this either. The transformed antibodies usually present in individuals with RA are called rheumatoid factors. The self-produced antibodies bind with their target antigens in the blood and the synovial membranes, forming immune complexes. And so the synovial fluid is that fluid that helps protect the joints and help with shock as we walk and use our joints. And so the synovial fluid becomes inflamed and infected as well. Leukocytes are attracted to the synovial membrane from the circulation, where neutrophils and macrophages ingest the immune complexes and release enzymes that degrade the synovial tissue and the tissue around the joints and the cartilage. And so what you see is the activation of B lymphocytes and T lymphocytes results in increased production of rheumatoid factors and enzymes that in turn increase and continue the inflammatory response, because we know that macrophages and T cells and B cells, all of that are part of our immune system to help us fight infections, and it sees the body as foreign, so it just continues to fight, and the inflammation gets worse. The synovial membrane is damaged by the inflammation and the immune responses. It swells from infiltration of the leukocytes, so as these fighters are going there, they just consume it, and there's so many, it causes more swelling in those areas. And then it thickens as cells proliferate and enlarge. The inflammation spreads and involves synovial blood vessels. Small venues are occluded, and then once you have this occlusion, then the blood vessels are occluded and the vascular flow to the synovial fluid decreases. As blood flow decreases and metabolic needs increase because of the increased number and size of the cells, hypoxia and metabolic acidosis occurs. And of course it will, because you've got a cutting off the circulation. Acidosis stimulates synovial cells to release hydrolytic enzymes into the surrounding tissues, and it starts the erosion of the articular cartilage and inflammation. So it's a very debilitating, as the process continues, it continues to break down and break down and break down. The damage to the cartilage that occurs in RA results from three processes. Neutrophils, T cells, and synovial fluid cells are activated and degrade the surface layer of the articular cartilage. Okay, so we got this process going on where they're attacking that cartilage. Cytokines, especially interleukins, and tumor necrosis factor cause the condocytes to attack the cartilage. The synovium digests nearby cartilage, releasing inflammatory molecules. And so basically it's attacking and it's eating away at this cartilage. And when the cartilage is gone, you have this swelling with the synovial fluid from all the macrophages and lymphocytes and things of that nature. The inflammation also causes hemorrhage, coagulation, and deposits of fibrin on the synovial membrane in the intracellular matrix and the synovial fluid. Pannus tissue, which is an abnormal tissue layer, includes newly formed blood vessels, may develop within the synovial membrane, leading to a greater loss of bone and cartilage. So again, the process just goes on and on and on, and it just continues to wear away and wear away. And so again, you see this, excuse me, process of continue attacking. The body's immune system's working and it's attacking, but it's attacking something that's not a problem. And so we don't know why. Some of the causes: osteoarthritis is the most common form of arthritis in older adults. It's caused by chronic degenerative changes in the cartilage and the synovial membranes of the joints. However, RA is the most common form of autoimmune arthritis. Remissions are most likely to occur in the first year of the disease, so you can have some remissions. And as you see, it affects people between age 40 and 60. And so usually the first year, you're dealing with it, but it's not that bad because you have these periods of remission. Approximately 10% of patients diagnosed with RA experience long-term remission within a year following the onset of RA. An estimated 60% whose disease does not enter remission within approximately 10 years will be disabled, won't be able to walk, maintain employment, or do anything for themselves. The cause of RA is unknown. Genetics, environmental, hormonal, and immunologic factors are thought to be some of the agents. Infections such as bacteria, mycoplasmas, and viruses, especially Epstein-Barr, may play a role. Genetic factors account for about 50% of this disease. Other risk factors, heavy smokers because of the vasoconstriction, cutting off the blood supply, obesity because of the weight, physical and trauma, damage, or emotional trauma. We know emotions can affect our healing process. Exposure to pollutants, so toxins such as in the air and insecticides, and toxins from occupational exposures. Absence of risk factors does not preclude, so sometimes we just don't know what causes it. So some of the clinical manifestations, and you can see this on page 528, joint deformities, and they're very deformed. They make it grow in an abnormal way, and you see nodules, and the joints are knotted up, and it's very painful. It's red, warm, and it may affect multiple joints. During the active phase, you may have fever, anorexia, fatigue, and these joint deformities, and a lot of it's usually in the hands. And so you will see that it's very painful. It says over time, the inflammatory process associated with RA produces these joint deformities. Sleep patterns, psychosocial well-being, and overall quality of life are effective in a negative way. You're hurting all the time, and as your fingers and hands get malformed, you can't use them. And so it's a very difficult situation to be in. The joint deformities or manifestations, this is on page 528, and you also have a comparison chart between osteoarthritis and rheumatoid arthritis. The pattern of joint involvement is usually symmetrical, but at the rate which joint deformities develop can fluctuate. And again, you may see it in the hands and the fingers and the knees. These are some of the most prominent areas. You have stiffness, and you can have this stiffness if you are sitting too long. It's very difficult to stand up. You may have swollen, inflamed joints feeling boggy or sponge-like on palpation because of all the synovial fluid in the area. And range of motion is very limited in these areas. You see a lot of severe disability. It can damage your organs, and it can also cause anemia as well. And then again, hands and fingers, wrists and elbows. Look at the hands and fingers. It talks about a swan neck deformity, and you can actually kind of see that in the patient's hands on page 528. It just gives you that picture of a long, elongated swan's neck, and the inflammation is unbearable. You also see visible swelling in the knees, the ankles, the feet, and the spine as well. And it's very painful, chronic pain all the time. Extra-articular manifestations, you see with a variety of these. They're seen particularly in patients with high levels of circulating rheumatoid factor, fatigue, weakness, loss of appetite, weight loss, low-grade fever, because it's an immune reaction, it's an immune response. Skeletal muscle atrophy because they're not able to use, get up and walk. As we taught in our last lecture on Tuesday, for back pain and walking helps build bone. And so they're not able to do that. So they lose the ability to walk, and so they lose bone mass as well. Rheumatoid nodules may develop generally in the subcutaneous tissue, and you can see this in a picture on page 530. You can see the nodule on the patient's hands as well. You have a high risk of increased coronary heart disease. You have direct effects on the blood vessels. You would do a lab called C reactive protein, and this indicates inflammation. The higher the C reactive protein, the higher the chance of more inflammation you have. The more inflammation you have affects the pumping action of your heart, and you are at high risk for having a heart attack and heart disease. Increased risk for having low density or low LDLs, and we know we don't want our LDLs low, we want them high, we want our HDLs low. And so what's our collaboration? What's our treatment? Once the diagnosis has been established, goals of therapy to relieve pain, reduce inflammation, and stop joint damage. There's no current cure for this. The goal is definitely a combination of resources that we use. Diagnostic tests, how do we look at it? The CBC and the platelets, the WBC, looking for inflammation, looking for decreased production of your white blood cells. With most of these patients, the WBC and platelet counts are usually normal. However, the inflammatory response may lead to an increase in both of these. Certain subgroups of patients may also demonstrate a decrease in the WBC count. The anti-CCP test detects antibodies, and you also have, again, the C-reactive protein. And then they'll do x-rays of the joints to rule out other things like fractures. And then it talks about different types of surgery. Early in the course of the disease, the synovectomy, this is excision of synovial membrane, helps reduce the inflammation because they go in and they draw off the synovial fluid. Arthrodesis, this is joint fusion, and arthroplasty, this is like a total joint replacement. Non-pharmacological therapies, there are 3 listed here for you. Non-steroidal anti-inflammatory drugs, so your NSAIDs, for reduction of inflammation and pain. Low-dose oral corticosteroids for reduction of inflammation and pain and to help slow the disease. And then you have disease-modifying anti-rheumatic drugs, or your DMARDs, and this is to relieve disease-related symptoms and to slow disease progression. And then you have a 4th one, intra-articular steroid injections, and so this is where they go right to the joint and shoot the steroids in, and that does help for several months, but then it comes right back. It's only a quick fix. You also have what's called the well, before I get to the COX-2, let me say this about NSAIDs. Be careful with the GI. Aspirin is also linked to GI issues. And so at the top of page 532, it says, while a risk for GI toxicity is associated with all NSAIDs, aspirin's incidence of GI toxicity is particularly high. In the treatment of RA, aspirin is also linked to other undesirable characteristics, including the need for multiple doses per day and a narrow therapeutic window, which means that even minor dosages can be toxic. And we know that aspirin irritates the stomach, and it's also an antiplatelet. So we don't really want to take a whole bunch of aspirin because it does affect many things. For these reasons, other NSAIDs or a combination of medications may be preferable to aspirin. Aspirin does treat the pain, but it's got several side effects that can be dangerous. Included with the NSAIDs are your COX-2 inhibitors. These NSAIDs work by selectively blocking the synthesis of prostaglandins generated by the way of the COX-2 enzymes. And so some of them are Celebrex is the only available medication in this class. And you have to be careful with Celebrex because it does affect kidney function and it does affect the GI tract. You do have to take these medicines, a lot of them with food. The most common side effects of NSAIDs are GI, stomach lining irritation, erosions to the esophagus, and bleeding ulcers. Take these medicines with food. However, the risk of GI bleeding is not decreased because it's still very irritating, even because in the esophagus, because the food's not there. You may want to take enteric-coated medicines if you can find those. You want to also take proton pump inhibitors such as Nexium or Prevacid or Protonix or Acifex, along with medications such as your Cytotec. These are believed to have protective effects on the stomach mucosa and reduce the risk of GI bleeding. Again, they can cause kidney damage and they can cause blood pressure alterations as well. They're extensively metabolized in the liver, so they're contraindicated with people with liver disease. Some people, because of comorbidities, cannot take these medicines, and they just have to deal with the pain and do other measures like creams and rubs to help inflammation, hot packs or warm packs, not hot, but warm. Okay. Some of the other ones are your corticosteroids, and of course we know these help reduce inflammation and immune reactions. Long-term use is associated with multiple side effects, and this is in box 10-2, and that is on page, and I don't see that. Look on page 531 and also on page 534 for medications. And please review your NSAIDs and definitely your immunosuppressant drugs, your cytotoxic DMARDs. Methotrexate is one of the most common ones given, and we're going to talk about that in just a minute. Prednisones should taper under the supervision of a healthcare professional because you don't want to abruptly stop it. It can be fatal if you abruptly stop that medication. Abrupt discontinuation of exogenous steroids may have disastrous consequences and may even be fatal. Patients who discontinue systemic corticosteroids should do so under the supervision of a healthcare professional. You have to wean them off slowly. Your DMARDs, again, these are a diverse group of medicines that modify immune and inflammatory responses such as gold salts, anti-malarial agents, and sulfasalazine. Benefits are not apparent for several weeks. These drugs can produce both clinical and improvement of modifying the progression of the disease, but again, there's no cure. All of these drugs are fairly toxic, and so they have to be monitored. You have to go in and get labs done for these type of drugs. You have your immunosuppressant drugs, and this is where methotrexate comes in. Methotrexate is a chemotherapeutic agent, but it is very good at treating rheumatoid arthritis. You can experience something called tumor necrosis factor inhibitors. These are used to treat patients with RA, include Enbrel. And so with these, you also have Remicade listed there as well. It's given by IV infusion. This drug is administered to reduce infiltration of inflammatory cells. Another one is Humira. And so a lot of these are given like once a week or once a month or twice a year. And some of these can be given by subcutaneous injections as well. You have gold salts, anti-malarial agents such as Plaquenil, and you have your sulfasalazine drugs as well, and steroid injections. Please read over those, okay? They're very self-explanatory because I don't want to make this PowerPoint too long. It tells you just what it needs to say. So there's your gold salts, and there's some of your reactions, and your anti-malarials, Plaquenil, and then your steroid injections, okay? Some of the things that we do that don't include medications, rest and exercise. low impact walking, low impact exercise. But you do need to get up and move around. The more you sit around, the stiffer your joints get. Physical and occupational therapy. They may need that to keep range of motion and let them do active range of motion. Hot and cold packs are used to help with the inflammation. Orthotic devices so they can walk and eat and manage their ADLs. And then nutrition. Some patients may benefit from substitution with omega-3 fatty acids found in certain fish oils. A lot of the physicians will say take fish oils for these. And then plasmapheresis, again to remove circulating antibodies, and total lymphoid irradiation decreases total lymphocyte levels as well. Acupuncture, hydrotherapy, fish oils, certain diets, hormone replacement. A lot of these are costly, so people don't do them. Juvenile considerations, juvenile idiopathic arthritis, chronic inflammation, autoimmune juvenile disorder, joint inflammation resulting in decreased mobility, swelling, and pain. It is similar to rheumatoid arthritis in adults. It occurs slightly more often in girls than boys between ages 3 and 6 and around puberty. No national studies have been conducted to determine the incidence in the United States. Many children do not complain of pain when symptoms first develop. You see joint pain and swelling and unusual patterns of walking. Aspirin is most often used to treat because it's fast-acting and expensive, but because of Reye syndrome, it should be discontinued if the child develops chickenpox or flu-like symptoms. Exercise is important, but you will have joint soreness and discomfort may intensify as they exercise. So, you don't see this a lot, but it can affect children. Again, there's 3 different types. Please just read over those 3 different types. They're listed on page 536 for you. And some of the symptoms you'll see is fever, rash, swollen lymph nodes, enlarged spleen and liver, slow growth, uveitis, chronic inflammation of the eyes and the eyelids, and it does interfere with growth. Pregnant women, you may have remissions during pregnancy, but relapse after delivery. They don't really know why, but it could be because of increased circulation and things like that. Low fat, high fiber diet, extra rest, and RA medications have safety risk in pregnancy. And so just read through that as well. It says routine consumption of oral calcium and vitamin D supplements is also recommended while you're pregnant if you're dealing with this. Prolonged bed rest and inactivity is not advisable because it causes you to lose muscle mass and bone density. Use medications with greater caution because older patients have comorbidities and they may not be able to absorb or metabolize these medications. They need to be up and moving, but it is not rigorous exercise. It is incurable, and so it is very physically debilitating, and psychosocially it does affect their self-esteem. And so we really want to work on that with our patients. We want to observe their gait and posture. Is it abnormal? Are they leaning? Are they walking with a limp? Do they complain of pain when they're walking? Are the joints stiff, red, swollen? Do they have contractures, fever, stiffness? Anything that looks out of the ordinary. Height, weight, are they losing weight? Are they losing bone mass? They don't eat because they're in chronic pain. A lot of these medicines take their appetite as well. There is a drug out there called Megace or Mestrol that can be given to help increase their appetite. And again, we want to look at the deformities on their hands as well. Here are your nursing diagnoses: chronic pain. Instead of acute pain, it's chronic pain. Role performance, fatigue, disturbed body image, anxiety, and definitely self-care deficit. And of course, we base the diagnosis on the findings. What do we find when we do the physical assessment and do the labs? And then your diagnoses, you see these are some of the things that, this is on the page of top 537, where they do the patient's history, diagnostic test, and the diagnostic criteria, and they base it on this European model that they use. Number and site of involved joint 0 to 5, and then serologic abnormalities and elevated acute phase response. Anyway, it's a scoring system that they do when they're evaluating you. Goals, pain management, performing your ADLs, and expressing your feelings. Again, implementing your interventions, so monitoring pain levels, addressing the pain with the medications, heat and cold applications, range of motion, giving the medicines on time, in a routine manner so they stay therapeutic in your body, and up and moving, giving the medicines on with food so they're not throwing them back up. Frequent rest periods, that's so important. There's a whole section on page 538. Balance your rest periods. Yes, they need to be up moving around, but not for 3 hours straight in a row. Maybe 30 minutes and then rest 30 minutes and then up again. You have to balance it, okay? And so we want to make sure that we're doing low impact exercises and range of motion. Address ineffective role performance. So we want to get other people involved, discuss the effects of the disease. How does it make you feel? They need to be able to talk about their feelings, listen to them, and involve family to help with the patient. Help them talk about their deformities, and encourage them to talk about the effects of the disease, how to maintain self-care, self-help groups, and give them information on rheumatoid arthritis as it continues to deteriorate their body. Support related to impaired mobility, the goals of physical therapy: function and strengthen the muscles, proper body alignment, and range of motion, stretching, hydrotherapy, swimming. Swimming helps loosen, the joints. That's very good for them. And then our evaluation. They maintain joint mobility. They can express their feelings. They maintain positive body image. They're patients free from infection, and they can express an understanding of the disease. And we hope that the pain is decreased. And that is the end of the lecture.